Greetings, welcome. We're going to look at our last video of this series. We'll focus here on burns and accessory structures of the integumentary system. So we'll throw in the hairs, nails, and glands in the last couple slides here. We'll look here in this video at what a burn is, how they're classified, rules of nines, homeostatic concerns following a burn, briefly looking at treatment and prognosis, and then accessory roles, or accessory parts rather, of the integumentary system. Incidentally, before we move on, looking here at a second-degree burn, and we'll talk about how you can tell that in just a moment. But understand that burns are caused by more than just heat. Heat is the one we most associate with burns, but you can also have chemical burns and radiation burns and even friction burns. So a number of things can actually damage the integumentary tissue and can even potentially damage the underlying tissue as well. One of the ways we classify burns, though, is on the depth of the burn, how much of the tissue got damaged. So if someone has a first-degree burn, like you see here, we're talking about the epidermis. The epidermis got burned either through heat or radiation or chemicals. The first-degree burns are painful. You feel a first-degree burn. If you've had a bad sunburn, you feel that. Though these are not going to be scarring episodes, and usually after 7 to 10 days, the burn is mostly healed. You'll peel the epidermis because that tissue got damaged, and it will peel away, and then you'll grow new tissue underneath it to replace it. A second-degree burn, like you see here, is characterized by blistering, and you might see, if you look carefully, some tiny blisters. Here's one over here. So you see the damage, but you also see some areas that are a little more damaged. For a second-degree burn like this, we're talking about damage to either the papillary layer of the dermis or the reticular layer of the dermis. So it could have gone either a little deep or even deeper into the dermis to give us a second-degree burn. These are described as the most painful burns because you have damaged a fair amount of tissue to get to the dermis, and even though it's painful, these typically are going to heal without much of a problem. You may hear of a term called a partial thickness burn. A partial thickness burn does refer to second degree. So this, by the way, this is first, second, this is about to be third. Gives you an idea. Then a second degree burn is a partial burn. It didn't burn completely through the dermis, but when we get to the third degree burns that you see here, a third degree burn is going to be where the epidermis got burned and the dermis got burned, and now the burn has extended all the way through those two layers, and this is referred to as a full thickness burn. Ironically, perhaps, these are not very painful burns, and you're thinking that sure looks painful, but since the nerves were damaged or destroyed in the dermis, then you typically don't sense a lot of pain with a third degree burn, even though it looks pretty bad. This kind of burn typically is going to require some grafting or some kind of scar prevention, because it's a lot of tissue to replace, and connective tissue will often get in there and create scarring. So that is a third degree burn, or it's also referred to as a full thickness burn. A fourth degree burn, and it's not great to look at, I grant you, but a fourth degree burn is where you've burned through the epidermis, you've burned through the dermis, you've burned through the hypodermis, again the subcutaneous layer, and you've burned down to the muscle and bone. Once again, not a very painful burn, even though it looks really bad, because you destroyed the nerves that were there. So this often will require grafting or even amputation. It may be that the tissue is too damaged to heal. So it's a possibility that someone who has a fourth degree burn, like you see here, is going to require amputation of that part. So how do we estimate burn area? When we talk about looking at determining how much of someone's skin was burned, there is a simple rule we can use for adults called the rule of nines, and it was mentioned on the first slide. Let me go ahead and put it back here. So the rule of nines is actually what you're seeing as a way of estimating burn area. What we mean by that is we can divide the body into regions that have multiples of 9 to determine surface area. For example, each anterior side of the leg is 9%, as is obviously the other leg. The back of each leg is also 9%. So the leg, each leg is 18%, or a multiple of 9. Same for this one. So we have the rule of 9 is the front sides and the back sides, anterior, posterior are each 9. So the entire lower legs here are 36%, anterior, posterior. Each anterior surface of the arm is 4.5, or the whole arm itself is 9, and same over here. The entire surface area of the skin of the head is 9. The anterior trunk, this front part we see, of course, is 18, as well as the posterior trunk is 18. So together, anterior and posterior trunk is 36. So all that together will be 99%. And then we include 1% for the perineal area, so that gives us 100%. And what that allows us to do is to say somebody who has a particular area, a location of burn, we can say, well, if they burned their entire left arm, or they burned both arms, we can then estimate burn area from that. We'll look at some examples here. Let's try this. Let me move me. A person who has burns on the entire anterior side of one leg has about what percent of skin burned? So if we need to go back, I can't go back. If we need to go back, okay, the anterior side of one leg. Well, since the anterior side is 9%, then that's the total answer for that one. They have burned about 9% of their total skin surface area. What about the second one? A victim was pulled from a car fire. She suffered burns to her anterior thoracic and abdominal region, her entire left arm, and the anterior of her right arm. What percentage of skin was burned? So let's look at that as a calculation. Her anterior thoracic and abdominal region. Okay, so that's how much? That's 18%. Okay, rule of 9s. Her entire left arm. Well, 4.5 for the front, 4.5 for the back. That's another 9%. And then the anterior of her right arm. So that's about 4.5%. So if we said, and let's even just use roughly 5 just for an estimate here, then we are saying here that roughly 32% of her skin surface area was burned, and that calculation, while it's rough, gives doctors something to work with. Why do we care about that? Why do we care about the amount of burn area anyway? Well, burn area is going to be very important to prognosis, which we'll get to in a second. Before I mention that, though, we've been talking about the rule of 9s for adults. This is true for adults, but it's not true for children and not true for infants because they're proportionally different. So there's some slightly different calculations you would use for an infant versus a child versus an adult. I'm not going to hold you responsible for knowing the child and infant versions of this. I am going to hold you responsible for the adult version, but I just want to make you aware that infant and children, because they're not proportioned the same way, you can't quite use the same rule of 9s for kids and adults like you can, kids and infants like you can for adults. So back to the question, why is it important to know how much of our area got burned and what homeostatic disruptions would we expect if the skin is damaged? Well, I think some of these are going to be pretty obvious to us, but a burn that's larger than 20% of the skin is going to result in some significant impairment of the skin. Recall that the skin is not just involved in being a covering, it's also involved in regulating our fluid loss. It's also involved in temperature regulation, and also helps protect us against pathogens. So if we lose more than 20%, we've significantly impaired a function of that system, and that can lead to some complications. This is just showing you the TBSA, which is represents basically total burned surface area, how much of the skin got burned. You can also just see the difference in hospital stays. If someone has about 15%, for example, of their surface area burned, then they're probably going to be in the hospital, 4 to 5 days roughly. But by the time that we even get out to 40%, you'll notice that now we're looking at a stay of about 44 days because of having to monitor that patient and actually aggressively trying to replace the skin or prevent infection. If someone has burns over 30% of their body, there's also a significant inflammation response, which can affect other organs. Burns over 50% is going to significantly increase their death risk. In fact, I have this chart. Let me move me for a second here. This chart showing you the prognosis in the United States, even with their health care. Someone who has burns, even up to 30%, they have about 8% chance of dying. But by the time that you cross 50, notice how much significantly more the risk is of, as you lose more and more skin area, you could have more and more homeostatic disruption, which leads to potentially death. If you have more than 90% of your surface area burned, you have an 85% chance of dying because that's a significant amount of area, and you're going to have significant impairment while you're trying to recover, if you can recover. So what's the treatment and prognosis for burns? Isotonic intravenous fluids. They're trying to replace a lot of fluids that are lost. We said before that the keratinized epidermis, when it's there, actually prevents water loss. If you burned away the epidermal layer, water is going to continue to escape. You're going to have more of that insensible perspiration, but you're going to lose a lot of water. So they're going to have to replace it isotonically so that you have enough fluid and you're not dehydrating. Obviously, wound care, managing the pain, and surgery may be required to close wounds or to do skin grafts. You see here on this slide a skin graft. There's this mesh that's put there. New skin is going to be used to try to heal that wound site. And again, the skin, if it can take, will prevent bacteria from getting in there, and it will also hopefully prevent extra homeostatic imbalances as well. The prognosis, how will they do, is most directly related to the burn area, that is the amount. Complicating conditions like many burn victims are also going to be smoke inhalation victims, and overall health. We can also throw in that there's some places in the body that get burned that slightly increase your risk even more. Burns on the face, burns in the perineum, burns that are on the hands can actually have higher rates of complications than burns, let's say, on the middle of your arm or the middle of your leg. Okay, so let's switch over here just a couple slides. Of just kind of tying up the loose ends with the integument. And again, we're not going to spend much time on these. First, talking about hair. For hair, just recognize that it's composed of dead keratinized cells, which sounds kind of familiar because obviously your squamous epithelium is going to be that way as well. But these scales here are, you start seeing the sort of these stacks of keratinized cells. That's what makes up a hair. Genetic and hormonal influences determine your hair thickness and pattern of distribution. So you're familiar with male pattern baldness. The reason we see that in males is testosterone actually can influence hair development, and more testosterone can sometimes inhibit hair development. So they will lose their hair over time. Hair grows on different cycles. So the hair that's on your scalp, for example, will grow anywhere from about 6 to 10 years, and then it will stop growing. At any one time, about 80% of your hair is growing on your scalp, and the other 20% is either not growing or it's kind of in a resting mode. Your eyebrows, just as a difference, they remain active for about 3 to 4 months, and then they stop growing. So the hair grows on different cycles. And it's important to realize that the hair is not actually alive. The thing that we're seeing here coming out the top is actually, again, dead keratinized cells. Where you see down here the hair bulb, that is actually the cells that are actually producing the hair to then grow through the follicle and to actually stick out from the top of the epidermis. Also recognize you have the erector pili muscle, which allows us to stand our hair up on end. And you don't see it on this one, I don't believe, no, but you actually can, there's going to be a nerve associated with each hair, so if your hair gets moved, then actually you can detect that, so it gives us some extra sensory perception. Some people will wrongly believe that you can get DNA from a hair. Again, this whole thing is dead. If you get the cells down here that actually are producing the hair, then those cells actually have DNA. So hair at a crime scene doesn't tell you much. But if the hair got pulled out in a struggle, for example, and there's DNA attached to it, or because the cells are, then that can be useful for identification purposes. Hair color is due to, this goes back to our old friend who? Melanin is responsible for hair color. Gray hair is actually due to an increase in, due to a decrease in tyrosine, the levels, the precursor to making melanin. So if someone's hair goes grayer, it's because they're producing less of that precursor protein. Very briefly, even briefer, nails. I'm not holding you responsible for knowing much about nails, except to recognize again that the part we're seeing on the outside, the nail itself that we can see, is dead keratinized cells. The root of the nail, actually down in here, is going to be live cells that as they grow, they push out the dead nail toward the surface. Oops. The lunula, I'll just show you that one. It's a little hard to see, but the lunula is actually that little half moon that you see down here. That's just, again, that's just a term for that. I want you to have that term. But in lab, you may do a little bit more with naming of the nail parts. Not that concerned that you know much about nails for this course. The only thing that you may want to remember about nails is that nails sometimes are indications of some underlying pathologies. For example, somebody could have a nutritional disorder, and that actually would change the nails. It may be rigid, or it may have an irregular color because of some nutritional concerns. And finally, I just mentioned glands. These are the last accessory structures. Glands actually come in different types. Here you see sebaceous glands and sudiferous glands. We've already briefly touched on these, but sebaceous glands are the oil-producing glands, and these are the glands that we associate with hair follicles. So here you see a sebaceous gland. It's going to produce oils that will actually help lubricate and protect the hair. So in most places where you have hair, you're going to have these sebaceous glands, these oil-producing glands. You're also going to have sudiferous glands more widely distributed. Eccrine glands and apocrine glands are two different types. Eccrine glands are the glands that we associate as true sweat glands. You have about 3 to 4 million of these things. They're all over your body, and they're going to produce a mostly watery sweat. Maybe it has some slight ammonia in it. It may have some slight other ions, but this is going to be the sweat glands that we associate with most of our skin. The apocrine glands are those that we associate mostly with our axilla and groin regions. So around the groin, under the armpits, you're going to find apocrine glands. In the bearded areas of males, you're going to find apocrine glands. And these are sweat glands too, but they're not really functional until puberty. And they really don't function as much to cool us down as to produce a more aroma-filled smell. These are going to actually produce stinky sweat, if you want to say it that way. These glands are activated by emotional excitement, by sexual excitement, and one theory about these glands is that they do trigger someone is not sexually active, someone is sexually ready to conceive. They indicate basically someone's stage of puberty. So that's why, when kids get to be 10, 11, 12 years old, all of a sudden they start to get this smell because these glands become active in part because of puberty. And finally, we'll mention a couple more gland types. Ceruminous glands that you see here are those glands that actually produce earwax. So inside of the ear canal, there's going to be ceruminous glands. They produce a wax which helps trap materials. And we'll also mention breast here because those, again, technically are going to be glands in the fact that they're going to have modified cells to produce a protein product. So, you know, they actually are very similar to, in many ways, sweat glands. It's just the product obviously is different. The term we often use for breast is that they are lactiferous, which means milk producing. So that will do it for the integumentary system. And when we get to our next system, we'll be talking about the skeleton system. Thank you very much.